Okay.
And firstly, I just want to thank you, Andrew, and Ram, and Teng Wai for helping us out with this webinar. The purpose of this webinar really is to try to get some learnings from Singapore in terms of how you have been dealing with the COVID-19 pandemic. Just for context, Royal Adelaide Hospital is our hospital. We're part of a Central Adelaide local healthcare network across 2 campuses. And I would say that we are in the stage of preparation. The community transmission is not as significant as it is in Singapore. Our numbers are relatively slow to increase, but we are preparing for a surge in the next 2 to 3 weeks, or hopefully later. So I just want to start off. I don't think Raj is on. I think Andrew's just left us.
No, I'm still here.
He's whispering.
I'm just, sorry, I'm in my office and people are knocking on my door. We've got Raj back. Fantastic.
Yeah. Good. So firstly, I might throw to Raj. Raj, if you can, I understand you're a vascular general and trauma surgeon. I want to ask you first, how did you prepare for the COVID-19 pandemic as a surgical unit?
Dealt with it. Oh, yeah. Go ahead, Raj. Sorry. No, sorry. Let me mute myself. Sorry.
Yeah.
So I think there are a couple of areas that you need to look at when you're dealing with a pandemic like this, and it varies from country to country. So whatever we're going to say is going to be quite customized to Singapore, for a country which has got quite strong contact tracing and limited community spread at the moment. What we did was, the first thing was we wanted to do was to protect the workforce, and that was by segregating teams and making sure that everyone works independently of each other in a way that does not cause too much strain on the ground. That's number one. Number two, we wanted to create ICU capacity and high dependency capacity for the eventual surge of patients that would come in. And this involves altering your work practices. It involves deciding what cases to proceed on, where to draw the line on electives, day surgery, and short stay surgery. And finally, in order to maintain some degree of surgical workflow and staff protection, deciding how are you going to get the patients into your unit, how are you going to screen them, based on what criteria are you going to screen them, and this is where it's going to vary from country to country. For example, in Singapore, and if we take that as our starting point, if you look at Singapore, because of the strong contact tracing abilities, the cases coming in are more or less screened already to a certain extent by the community. But once they come in, we take on a secondary screen, looking at their contact history, the presence of pneumonia, be it clinically or via CT or X-ray, and decide whether these patients need to go for additional swabs to determine whether they're a suspect or a non-suspect case. Suspect cases are treated differently from the non-suspect cases in the way we isolate them and in terms of the protective equipment that we use. Similarly, there are lots of other smaller changes down the line in the operating theatre that we put through for patients who need to go, who are COVID suspect or positive. Moving into the workforce and going into what we do about the teams is how to segregate teams. Team segregation has got the advantage of protecting the workforce from each other, but it comes at the cost of thinning the workforce on the ground. For example, when you have the same cohort of patients, when you segregate your teams, especially at the junior level, it means at your intern, your house officer level, and your resident level, that's when you feel the strain the tightest, because you have split this group into 3. And watching out for their welfare, watching out for their coping ability is key. And we do this by frequent surveying, readjustments of the plan, and being very dynamic as to how we keep people separated so that they don't burn out. Because that truly is what we find is the weakest link. Because once your junior workforce goes down, that's when you run into trouble.
Yeah, thanks, Raj. I think I'd like to take on that issue of workforce management as an important issue, perhaps towards the end. I guess when you were preparing, you relied on some of the lessons you learned from the SARS pandemic, which is now, 20 years ago. So I know, Andrew, as a vascular surgeon, a lot of your work I guess, is emergency work. Did you, as a vascular surgeon in your unit, and I guess I'll ask Raj as well, did you stop elective surgery as soon as you felt that the situation needed, and if you did so, how did you manage the elective work?
Thanks, Peter. Thanks, first of all, for asking us all just to come and share our experiences. There's two real points that I want to drive home that Raj has touched upon, and we keep coming back to it. I think the first thing is context is key. And what we've done is not universally applicable to the rest of the world and not even the rest of Asia. Each local ecosystem and healthcare system and vascular surgical service delivery is different, and it will very much depend on your context. So that's the first thing to say. The second thing to say is that these things are dynamic, and your decisions that you make today will probably be different to 2 weeks' time if you do have a surge, and in 4 and 6 weeks' time, you'll have to constantly readjust your position. And we've learned this as we've gone along. So there are 4 vascular surgeons here in Singapore. Raj supplements us on an elective basis and on the on-call, but he's been fully drawn over to the trauma service. So we would have been 5, but he's now doing pure trauma. We also have an associate consultant level who's had to support our middle grade. So from 5.5 consultants, we're now down to 4 effective consultants. And that is how we based our service on doing a 1 in 4 rota. The second thing then was, how do we achieve clinical segregation such that if one of us were to get exposed and infected, we would be able to manage the service? And so we decided on a 4-week rolling rota system where one person would do clinic, one person would do theatre, and then 2 people would be in the office doing administrative work, duplex reporting, that kind of thing. And it was purely practical. If we had 6, we would have done something different. If we had 8, we would have done something different, but we have 4 effectively. So that's how we started. And in the first instance, the theatre week, we had somebody who was on call every day for 7 days. That's not unusual for us. We do blocks. But we also then operated a consultant of the week model where one consultant would round everybody's inpatients and would do all 4 elective lists that week. Now, that was exceptionally arduous in the first 4-week cycle. But at that stage, we hadn't cancelled any elective cases. We were just looking at what was happening with the numbers, what was happening with the community transmission rate. And we tried that for the first 4 weeks. And it was a very difficult week, but we managed it and it was fine. Come the second round, we realized that actually we need to start protecting our beds. And so we began to slowly cut down on the elective work. And we started with the sort of the low-hanging fruit. So day surgery, elective fistula creation, non-urgent fistuloplasties and angiograms, varicose veins, those all went quite early on. So within the first 2 to 4 weeks, the decisions to carry on with those kind of operations was taken that we wouldn't do that anymore, and then we delayed. We're now coming to the end of the second 4-week cycle, and Singapore is now probably in what we are deeming to be our second phase or our second wave. All our cases are, whilst community transmission has been relatively well controlled, the numbers are going up a little bit, but most of the cases are imported cases. And so the big spike that we've seen has been a transmission back from Europe, from North America, from the United Kingdom. And so we can't ignore that. And even though the quarantine procedure and the stay-at-home notices have all been issued and the borders are been very tightly monitored, we can't deny that the numbers have significantly increased. So when we started 8 weeks ago, we were at 30 and we're now at 1,000. Now, we accept that many countries would love to be in this position of only having 1,000, but we're not complacent, and 1,000 could easily become 5 or 10,000 if we're not constantly on it. So we have to protect our manpower and our resourcing. And so we've now gone to the stage that we're now only doing emergency work. We haven't been as didactic as some other places, saying that aneurysms of 7 or 8 centimeters count, or a critical limb has to be a Rutherford 5 or 6. We're not quite that didactic. We're still leaving it to individual clinician preference. But essentially, if you need an emergent vascular operation, you will get one. But aside from that, all elective operations are cancelled. The only other thing to note, and I'll let Ram speak to this a little bit more, is that we are also one of only 2 ECMO centres in Singapore. And so as the numbers increase, we have to make provision for the ECMO service, and that will have ICU resourcing issues, that will have cardiac surgical issues, because vascular surgery is a part of cardiac surgery as part of the National University Heart Centre, at least here in our institution. So we are aware that even though the numbers are increasing, the number of ECMO patients we might need to support will increase as well. And therefore we have to constantly be watching our backs and watching our resources and waiting for that potential spike. If it never comes, then we've done our job. That's brilliant. But if it does come and we're not ready and we've clogged up ICU with vascular patients, none of us will be in a very good position at all. So yeah, context and dynamic movement and constantly reassessing the situation.
Thank you, Andrew. I want to just take us on the journey now. I mean, because you've provided us, and I thank you again, our panelists that are surgeons, anesthetists, and intensivists. I want to take us through that journey. So Teng Wei, I might bring you into this. We, of course, are preparing to operate on COVID positive patients, and there has been in our facility, obviously, some concern about, the risks to our anesthetists. And I note your letter to the Canadian Journal. I wonder if you could take us through how you as an anesthetist have dealt with the issue of either a COVID positive patient or a highly suspect COVID patient that your surgeons want to operate on. I think you're muted, Teng Wei.
Hi. Right. Hi, can everyone hear?
We can hear you.
Yeah, okay. Yeah. So I think the first step is to identify whether the surgery is urgent. If the surgery is not urgent, then we will do either 1 or 2 swabs according to the low risk or high risk criteria. If we get the swab clearance, then it makes the workflow easier. We will do it in the clean operating theater. If the surgery is urgent and we can't wait a 6-hour turnaround time for our swabs, or if it's overnight, we don't run swabs overnight, and the surgery needs to be carried out overnight, then we will run it in our isolation operating room. So the isolation operating room is currently maintained at the negative pressure is on 24/7 to cater for the COVID-19 patients. And we have actually run some cases, some suspected cases, including CABG in these theaters. The most challenging part is the pre-operative part, where it involves a lot of preparations, because the operating room is actually almost empty. It has one anesthetic machine and no surgical equipment. So the surgeons will need to provide the nurses with a list of equipments they need and a list of potential equipments they need, so that the nurses can bring it into the operating room. This is to minimize the amount of equipment that we need to sterilize after the usage. For urgent equipments like airway equipments or drugs, those are found in the induction room where the patient doesn't have access to. It is just right next to the operating room. So that room is kept at negative pressure, and we usually try to bring all that we need into the operating room prior to the patient arriving to the operating room, so that we do not need to enter the anesthetic induction room when the case is ongoing. But if in any case there is an urgent need, we will then doff off our PPE and we can still enter the induction room to get emergent equipment or airway equipment. So the most important phase is really the pre-operative phase. Of course, initially we find it a bit difficult. We tend to miss some equipments, and we have come up with some bundles or package. Like for example, if we anticipate the need of an IA line or a CVP, we pack everything into a package rather than taking isolated things, so that we can minimize missing things, and we have packed common equipments together so that we can take them in bundles rather than isolated items. We have yet to run CAT 1 Caesars in, but I think they have drills on that before. Yeah.
Then I might come back to you in a minute, but I wanted to just throw to perhaps Ram as well. One of the issues, of course, we're dealing with is the careful and judicious use of PPE. So I guess I might go to Ramnath, the intensivist, and see does your hospital have a protocol for the appropriate use of PPE, and if so, how do you determine that?
Yeah, thanks, Peter. Fairly, it's so as much as the PPE goes, there are two things we need to note. Of course, our hospital has a clear-cut policy on how we're going to approach these COVID patients. So what kind of PPE we need to wear when you're inside the negative pressure room, and what kind of PPE you need to wear when you're doing aerosolizing procedures. So those things are pretty much, we are pretty much guided by our Ministry of Health. They have laid down clear-cut guidelines as to under what circumstances, what kind of PPE should be worn, whether it's general ward, OR, ICU, negative pressure room, wherever. I mean, things are very clear-cut, and it's also very much, I mean, there is clarity on the fact as to what kind of healthcare workers would wear what kind of PPE as well. So that way, we were, I mean, at least these things were planned prior. The second thing I wanted to highlight with regards to personal protection is the fact that early in during the course of the disease, as well as learning from the SARS experience in 2003, Singapore invested in PAPRs. So these respirators, which we use, and we've been getting a lot of them during this outbreak as well, helps us with two things. One, they are reusable. So essentially, even if there is a situation where you run out of N95 masks, you are definitely backed up by adequate PAPRs, which you would be able to use in these circumstances. So it's not that we just got them. We were adequately trained on their usage. Late January, early February, we did quite some simulation exercises on donning and doffing of these PAPRs. We also followed up with wearing of these PAPRs in certain simulations where, you simulate, say, cannulation for ECMO and other things. So even, small surgical procedures, wearing PAPRs were attempted to see how much it affects your visual acuity, how much it affects your hearing acuity. So these things, I mean, it's essentially a new device, and it's just a question of how much you can adjust to it, to using it. that counted. So we did prepare ourselves on that front as well. So yeah, I mean, in a way, I think, we don't feel complacent at this point of time. There is definitely, at least the hospital authorities tell us that there is adequate stock of PPEs currently available. There is clear-cut guidelines on what PPEs to use. And given the fact that we have segregated wards into clean wards and dirty wards, we have reduced the use of essential PPEs in a big way. So the clean wards, you don't have to worry too much about personal protection, while the dirty wards get most of the PPE equipments. So, that way, there is no abuse of PPEs in a big way.
I might go back to the surgeons on the panel. I guess we are seeing guidelines coming out by the day from our colleagues in Italy, Spain, the UK, and we're, somewhat rattled by some of the, healthcare workers, some of our colleagues that have, been exposed and some have paid the ultimate price. How do you handle, firstly, I might go to Ram and then to Raj and then to Andrew, dealing with, which of these guidelines will guide, your surgical teams as to who gets to use the PPE and who does not, and which procedures should not proceed and so on. So Raj, could you tell us what your
So there are two parts. So there are two parts to this. Number one is, first of all, what cases are we proceeding on? So as of now, to preserve ICU and high dependency capacity, we only proceed with oncology and trauma cases, and of course obstetric cases. All other non-essential short-stay surgeries, day surgeries have all been cancelled as a measure. Just about a week ago, however, we were still doing day surgery in order to, since they did not take up a bed in the hospital. But as we see the need to ramp up training of the healthcare workers, we are stopping that as well from next week so that to release everyone for training. So the first principle is emergencies always. Oncology, we are still doing. Trauma, we're still doing. And obstetrics, we'll still do. And we haven't restricted that at all. Number two is how do we protect the workers? So PPE recommendations are quite varied, as you can imagine, around the world. For us, we have taken quite a pragmatic approach to it to say that if you're performing surgery on a COVID positive or suspect patients, at the very minimum, you have an N95, goggles or a face shield and a gown. Now, if you're doing a procedure near the airways, we have still maintained this as the minima, but we have given surgeons the options of using a PAPR set, for example, in cases like a tracheostomy, if they have been trained in the use of PAPR. One issue with the use of PAPR and PPE is that if your training is poor in these areas, using them may be even worse than if they're not using them. So training comes in quite closely together with this policy. But lastly, in terms of the actual minute details of how we operate, there are a few guidelines we have put in place, and the biggest debate raging at the moment is laparoscopy versus open surgery, with the concern that in laparoscopy there's aerosolization of the droplets, and if not filtered, they could vent out. And even the use of filtration system like from Valley Lab, Medtronic and all, they are not completely shown to work in COVID. They've been demonstrated for human papillomavirus, for example, but not specifically for the coronavirus. So we haven't put a strong recommendation on that, but for emergencies, we are recommending open surgery unless the risk-benefit ratio of laparoscopy is completely, is comparable to open. So if a patient really would benefit significantly from laparoscopy, then we will still consider it on a case-by-case basis. For simple appendices, for example, where we feel the hospital length of stay is not going to be too different, we are advocating open surgery for all COVID suspect and open cases. This is controversial. We are still seeing that new evidence come out, but we thought this is a pragmatic first step to proceed. We are not going as far as to give a blanket recommendation, not for laparoscopy, simply because, again, there are ways to mitigate by using filters as well. And so we are leaving it on a case-by-case basis, at least from that decision point of view.
Peter, we've lost your sound, I think.
Yeah.
Yeah. So I think so. That's been our broad approach. Again, we do try to screen everyone who comes in for surgery, with as long as they have high risk features, acute respiratory symptoms, pneumonia, or if they have a travel and contact history. If they don't at all, we don't screen them routinely at this point.
Right. I think you've got me back now.
Yeah.
Yes, we do.
So Andrew, just before I ask you to comment on guidelines, I want to also use the theme of training for appropriate use of PPE and PAPR. If you can comment how your hospital prepared people in that respect, and also your thoughts on, how to deal with these myriad of guidelines that are coming through.
Well, I mean, I actually have a unique perspective on this because I was working in the UK prior to coming over to Singapore, so I wasn't present for the SARS outbreak. And as part of induction, when I first got to Singapore in sort of late 2015, one of the most important things was a mask fitting, and to decide whether you were an N95 mask wearer due to your face shape or whether it was a different mask. And to be honest, my whole medical training, undergraduate and postgraduate in the United Kingdom, I didn't even know what an N95 mask was. So there is a level of awareness in Asia, and in particularly in the SARS hit countries, which is just not present anywhere else because obviously no one's had to deal with it. So as standard, they did N95 mask fitting even when I started. When they knew this was happening, everyone was made to redo their training because we have mask fitting and mask training every year. And then for those, my wife's a physician, for those that are manning the pandemic wards, there was, again, very specific training on how to use the personal respirators and how to don and, most importantly, remove the PPE in a safe, controlled way. So that was all done very, very, very early on. And like I said, the SARS experience does mean that people are much more aware of these things. I think in terms of the guidelines, just speaking generically now, Singapore is a very different ecosystem, as I've said, to say Spain. It's different to Italy, it's different to the United Kingdom, and it's very different to yourselves. I think guidelines are important. I think in times of crisis and in times of confusion, people look to guidelines. But unfortunately, I think the only guidelines which really make sense are the ones that you do for yourselves locally, because only your physicians and clinicians on the ground will know exactly what resources you have, what patient cohorts you're dealing with, and what the issues are. And, just from a vascular perspective, as a vascular surgeon, Peter, I'm sure you've seen guidelines coming out from the US and things. They're not immediately applicable. The American College of Surgeons recently came out with these blanket guidelines, which they don't make sense to me. And in my practice, they may make sense to what they're doing over there, but equally they've got an exponentially rising infection and death rate, and their hospitals are being overrun, particularly in New York State. So, that doesn't apply to us here. And so I think you need to be sensible. I think you need to be practical. I think you do need to be aware about what the rest of the world is doing. But I also think you must contextualize it to what you guys know best, which is your own healthcare system.
Excellent. Thank you. And I think, when I was listening to you at the PanSurge one, it's the context of these things that you have stressed on. Ting Wei and Ramnath, I've had a question about airway management. Firstly, Ting Wei, in terms of airway management for your anesthetic staff, I presume you do have a protocol for how intubation and extubation occurs, and could you just take us through that?
Yeah, for all suspected or confirmed cases, we will wear the PAPR with full PPE. So all our staff are trained in wearing the PAPR. So our department covers the airway code service for the entire hospital as well. So we will wear the PAPR for the airway code services as well. We have run some simulation, and it takes about 4 minutes for us to don the PAPR and PPE in properly. So we do have to take that into considerations about the urgency of the situation. Yeah. So, but the guidelines for the suspected and confirmed cases, we will use a PAPR and PPE unless it is really, really urgent.
Mm-hmm. And there's a period of time prior to you talked about the empty theater and the period of time after intubation. Is there a period of time prior to allowing the rest of the surgical team to get into the theater due to droplet spread?
Yeah, so the hospital guideline for us is that the surgeons will still wear PPE with N95 for their operation, whereas for the procedurists who do aerosolizing procedures will be in PAPR. So after the airway is secured, we will allow the surgeons to be in the operating theater with N95 and full PPE.
Mm-hmm.
There is no lag time per se in between how there is no time from the time of intubation to the surgical time.
Yeah. Ramnath, question was about long-term ventilation patients, tracheostomies. The policy is unchanged?
Yeah, it is. There is, I mean, like, we try not to tracheotomize them up to a certain extent, but, having said that, the policy remains the same. Tracheostomy is considered as a high-risk procedure, and the same kind of precautions which Tengboy just alluded to are taken for tracheostomy procedures as well. In the ICU, essentially, patients who have tracheostomy, the healthcare workers taking care of them go through the same kind of, they're put in negative pressure rooms and have the same kind of PPE precautions, nothing different.
Mm-hmm. One of the issues in terms of, and we've been focusing our discussion really on the management of the COVID positive or COVID suspect patient. But of course, we have a lot of other patients that still need to be managed, whose healthcare needs are still required, their surgical needs are required. Raj, I think you mentioned about splitting your teams into two. How do you keep your teams engaged when they are non-patient facing in useful and productive work? I'm curious about how you manage that.
So I think the concept we have to move away from is not people work at work and people at rest. What we do is we keep everyone at work, but in geographically disparate areas. So we have one team who is the inpatient team looking after emergencies in the main operating theater. The second team handles outpatients and sees outpatient clinics, and the juniors actually provide remote support to the inpatient team. So if we have, because by now, once we split the teams, the doctor to patient ratio is immense. You have one doctor to around 20 over patients. And what we do is we use the remote team, which is not in the building, sitting in our offices, connected to electronic medical record, doing changes, calling for scans, doing the summaries. And because they're geographically disparate, we have kept them segregated, but they are still at work and they're an important resource in supporting this very lean inpatient team. And that's the paradigm shift that I think we found very useful. And that took a lot of pressure off the inpatient team because, in a sense, they had a call center helping them do all these other changes without having to physically be there. There are a few things. So we use Zoom. We use Zoom to dictate the rounds live. So someone else typing it onto the systems live for ordering scans and all that. And we use that extensively during the round itself. And that has actually changed the way we work altogether. It may be even something we bring back to peacetime because it minimizes the number of people we need on the ground because you have this remote team. That's how we use the people who are not at work physically.
Mm-hmm. Andrew, I might bring you into this. Clearly, we have cancelled the FRACS final exams. We have surgical trainees at all stages of surgical training. This is, catastrophic in terms of the flow of their training. How have you dealt with that, Andrew, and maybe after that, Raj?
Look, the exams are an issue that are very difficult to deal with. I mean, this has happened in the UK when people aren't allowed to sit the exams that determine which universities they go to. We've had Cambridge University Medical School deciding that there will be no final set. They will just be passed through if they have a good and regular level of passing previously. Imperial College decided to move all their exams online. It's a much bigger problem for them, for the whole medical profession, really, because, you know, in particular, can you justify in good medico-legal conscience or in any other allowing somebody to become a fellow of the college without the exam? It's a very simple question. I would argue no, right? Maybe MBBS is a bit different. I also have my reservations about that, but we are in difficult times and we don't know how long this is going to go on for. I don't think the exam problem will be resolved instantly. I don't think there's an easy answer for it. In terms of surgical training, well, we've managed to keep our trainees on rotation for as much as we can, but there is a obvious and significant volume reduction for everybody, and that will directly impact on training. Now, there's lots of other things they can do. We haven't felt the desperate need yet to deploy them to other places. They are still acting as surgical registrars and surgical SHOs, but, you know, if there comes a point that they need to be deployed elsewhere, then that will become an issue as well. I'll let Raj talk to it a bit more because he's actually one of our program directors for surgery, but this is something that we're constantly worried about. So Raj?
So I think, Andrew, just to echo what you said, the biggest impact we see is in rotation planning as well as in case logs. We can't make up the case logs much. We found that by reducing from a 3-team model to a 2-team model, we're allowing our registrars a bit more exposure. So that's another advantage of having a slightly fatter team, because you have a bit more of a training opportunity. Now, that said, we don't use COVID patients as a good teaching moment regardless. So if you're having a COVID patient, we just want the fastest surgeon to do it as quickly as they can and come out. And so those are not teaching moments. But for all the other surgeries, we still try to encourage them to go in. We do try to maintain their rotation plan because this is a long drawn campaign. And you will have a lot of implications in rotations if you start keeping people away from where they're supposed to go. So that's one. Number two is how you assess people. So we are moving a little bit away from just the typical intraoperative surgical assessment to a more competency-based assessment using a variety of measures, using case discussions and vivas in order to get a better sensing. I think one important tip I would say is that do not stop your teaching. Try to continue your teaching as much as you can using Zoom and other telehealth platforms. The simplest thing to switch off for most units, I feel, is the teaching element as they go into crisis mode. But maintaining that sense of normality, maintaining teaching via Zoom is an important portion for the residents. And I think that helps them in their overall development, and it keeps it real for this period of time.
What are you guys doing with your medical students? Maybe Ting Wei and Ramnath can take that one if you've got engagement with your medical students.
Hi. Currently in our department, we do not have any medical student. We know that our medical student only come to anesthesia department for 2 weeks. So fortunately, they don't come in this time round the year. But some of the anesthesia exams for the student as well as for the specialist has also been postponed. Yeah.
Have you got Ramnath? You probably got intensivist fellows and anesthetic fellows rotating through your unit?
Yeah. So our policy with the intensive care fellows, at least for now, at least with ours, because in NUH, the number of ICUs are quite large, and it is run by various intensivists with various backgrounds. So there is the MICU, which is run by respiratory specialists. The SICU is run by anesthetists. The cardiothoracic ICU is run by intensivists who are trained in ICM per se. So at least with our fellows, we may, or we have at least taken the decision that we wouldn't expose them to the COVID patients early. In terms of their training requirements and weekly teachings, we do that on Zoom. So that's what is currently being carried out. And coming back to your question on the medical students, I do work with the Yong Lulin School of Medicine with the undergraduates. As of now, the medical students don't come to the clinical section, and they have been quarantined already. They've been asked not to come to the wards till the 31st of May, if I'm right. But there will be future directives on this as to whether this will continue for a longer time.
Mm-hmm. Can I throw the question of, if I understand correctly, the rate of healthcare worker infection in Singapore is very low when we compare it to Spain and I think parts of the UK. So there's an element of staff safety we've discussed, but also there's an element of the fact that I think you raised the fact this isn't something that might just finish in a month. This might go for 6 months or forever, however long. How do you look after the well-being of your staff?
So I think if I could, I'll answer one component of this is that I think that mental health and physical health are quite interlinked. We try to maintain normality as much as we can in terms of allowing people to take their leave, clear their leave locally. We don't allow them to travel, but at least gives them those break points so that at least there's some separation from the rest of the hospital. That's number one. So some sense of normality. For the juniors in particular, who are the highest risk, I feel, we survey them very often. So every few weeks into the work cycle, we send them surveys about burnout, medical safety, and we reassess what are the things on the ground. So they feel they have a say in what's going on. And we try to engage them as often as we can. So we hold these mass briefs over Zoom for everyone so that everyone knows what's going on and they are kept in the loop so they don't feel they're just working with no end in sight. So they see a bit of the bigger picture. And I found those to be quite helpful. I think in Singapore, we've always had this culture of working when you're sick and coming to work when you're not feeling well. And that is something which the leadership has to be quite firm about, to say that if you're not feeling well, it's your social responsibility to stay at home and you're doing more harm to your peers if you're not. So we're finally seeing doctors going to get the medical help and going to get treatment when they need it. And that's actually quite a nice change to see, which we have seen over the last few weeks.
Mm-hmm. Andrew, one of the issues which is different in Singapore to our current policy is the screening of the elective patients. We have epidemiological and clinical criteria for screening for COVID-19. But my understanding is if you're an elective patient in Singapore, you will require preoperative screening for COVID prior to being operated on. Is my understanding correct?
That's not been my experience in vascular anyway, and I'm pretty sure that's not the same in general surgery, is it, Raj?
No, it's not.
No. So we're not pre-screening. I just had a side chat with Jane on the chat just now. I was saying that we benefit from having an extraordinarily good contact tracing policy in the community and extensive testing available. So unlike the UK, where I've been, liaising with my colleagues, particularly in the context of the Pan-Surge webinar, they have to assume everyone's COVID positive because there's such extensive community transmission and there's such a lack of available tests and they can't get them quickly. Public Health England were taking about 5 to 7 days to turn around one test. And, there's no urgent surgery that can wait that long, realistically. So they have to have a very different mindset to us. I use that term loosely. I don't mean safely, but I assume that if they're asymptomatic, they're probably negative. And if I see them in clinic and they need something doing urgently, I'm quite happy to do that, operate on that, and just use standard surgical protection with no additional issues. The only other thing I want to say, Peter, is just in terms of, how do you look after your staff? Well, I was talking about that 1 week where we were on call, doing all the emergencies, doing all the inpatients, doing all the referrals, and 4 elective lists a week. I mean, it was very, very difficult. And we've realized that actually this is going to go on for a long time and it's probably unsustainable. So in this third 4-week cycle for vascular surgery, we've moved to a different model. We still have 2 weeks clinical, 2 weeks non-patient facing, but in the 2 weeks clinical, we're pairing up with a consultant partner and we're going to work as a team. So we will probably alternate the days on call, and rather doing a week of operating and a week of on call and a week of clinic, we'll probably do clinic, theatre, something like that, and alternate the weekends as well, just to give us a little bit of respite in the busiest clinical period that we have, because we are still doing the work of 4 people, and it was originally just being done by 1. We've decided that we'll just do it by 2. We hope and pray that none of us get infected, because if that happens, then our 1 in 4 rota instantly turns to 1 in 3. And so these are, constant considerations that we're constantly having to refine and change. And it will almost certainly change again in another 4 to 6 weeks, depending on what happens in the hospital and in the country.
Mm-hmm. So the issue of contact tracing, I guess, for healthcare workers, either inadvertently being exposed to someone with COVID-19. What is your definition of close contact?
So we use, we have a team, an epidemiology team, which helps us with this, but essentially more than 30 minutes of unprotected or suboptimal protection with a patient in a distance of less than 2 meters for us is significant. So that would mean, for example, you have done an entire long consult in a room with a COVID positive patient with simply a face mask that would, without any protection, that would constitute potentially a breach of that. And you would be now a person who may need to be sent home and on surveillance for watching your symptoms. So we have an epidemiology team with the infectious disease consultants, which helps us with this decision making based on their rubric. But the essential components are level of exposure, time of exposure, and how well were you protected. And based on this rubric, they'll tell you whether you are still considered a significant enough contact to go home or simply just be on phone surveillance and for temperature taking.
Mm-hmm. Mm-hmm. And I guess the public health measures in Singapore, we hear now that we've taken, in South Australia and Adelaide, we've taken more and more significant steps to lock the community down. In Singapore, at the moment, coming through the second wave, do you see a relaxation of these public health measures in some respects to?
Singapore's always had this policy of progressive breaking, in a sense that we apply measures in a gradual fashion, but progressively so. So we haven't gone into a straight lockdown like many countries have, but you can see the progressive introduction of new measures, of social segregative measures in society. We've just started doing a little bit of this tele-learning from home for the schools, for example. But if we find that, the community spread is worsening and school spread is worsening, then shutting down schools may become an option. But it's been a very progressive movement of social segregation rather than a one-stop, everything closed kind of policy. And again, it's specific to Singapore because of the contact tracing ability. The contact tracing ability, there are 20 teams in Singapore using the equivalent of Scotland Yard, essentially, to do contact tracing. The police are involved in the contact tracing to help to mitigate the rise of the clusters. Once we lose capacity of being able to do this, then I'm sure we'll progress quite quickly along the social segregation measures.
Mm-hmm. Mm-hmm. Andrew, did you have much to add to that? Because I guess we're looking at a long-term response, not just in the community, but the surgical community and the healthcare workers as well. We have families, and you've got families and so on. How do you ensure that people, in fact, are able to stay the distance?
Oh, look, I think it's a good question, but I think this is more. It's going to be more cultural, and it's going to go to the strong government. So if you look very closely, aside from all the, in terms of just the numbers, the one thing that Singapore has been praised for internationally, and you have to stand up and applaud that, is the governance and the way they've managed this. Prime Minister Lee Hsien Loong took it upon himself at a very early stage to address the nation. He has repeatedly told people very factually based information. We have, very early on, we had a WhatsApp chat done by the government, but that would give you exactly where the new cases were, where the new clusters were, how many there were, how many imported cases there were. So people have a sense of ownership. They understand and they can feel if things are getting worse, and they can see it for themselves. The numbers are there, and the progressive measures have come in as those numbers have risen. I think the difficulty is that, you know, there is no end in sight at the moment, and we don't know where this is going to end, and therefore a progressive measures will help society deal and change as things go on. I think, you know, I've got lots of family in Malaysia. They're struggling. You know, it's total lockdown except for essential items, and that's going to be extended. And if you keep a population like that under that kind of control, it can be very, very difficult. We'll have to wait and see. I don't have any more answers than that, to be honest.
Yeah. One of the things that I noted from listening to some of our Spanish colleagues was about the use of CT chests prior to, you know, operating on asymptomatic patients. Is that something perhaps Ram could comment on?
That's not something which we routinely do here, Peter. So sorry. Sorry.
Yeah.
So, you know, we just go, I mean, again, you know, it in a way, it was good to have the directives clear right from the beginning. So not unless and until there is a suspicion, there is a travel history, or there is an exposure, these patients are not subjected to unwanted tests. The kind of tests which we do to screen are pretty standardized. So not to answer your question, not everyone gets a CT scan here.
Some of the questions that have come in, and thank you all the panelists for responding to those questions. But I think there was some questions about selection of procedures, you know, laminar flow theaters for orthopedic surgery, and whether certain types of orthopedic surgery. I don't know whether, I know Andrew, you might not know, but maybe Ram does, whether there's certain orthopedic procedures that have a high risk of aerosolization that have been either deferred or stopped.
Not quite. I don't think we have deferred any of the orthopedic procedures per se, except for especially for the trauma-related ones. But most of the elective arthroscopies and knee replacements, they have been. Arthroscopy itself doesn't cause that much aerosolization, so they have no real issues with that. And most of the drills and all, I mean, the risk, I mean, we haven't really re-stratified to that level or restricted surgery on the orthopedic front based on that. Are you aware of any other restrictions they have? I don't think so.
No. So in fact, if it's a trauma surgery, for example, neck or femur fracture where we need some implants, actually the isolation theater is positive pressure and laminar flow inside the operating room, but the negative pressure is at the ante room and the induction room. So that provide the sterilization criteria for implant surgery, even at the isolation operating theater. Whereas for patients who are not suspect or not confirmed cases, they are done in usual operating room where the theaters have laminar flows.
So guys, we've got 5 minutes left, and I wanted to actually use the 5 minutes to ask you guys individually, how are you going? Andrew, start off with you.
Look, I must admit, I'm okay. My immediate family are all in London. My brother's a junior doctor. My mum's a district nurse. So I'm far more worried for them than I am for myself. I'm very fortunate to be in Singapore. Singapore have got a great handle on it. I'm happy to be a part of that process. But obviously I'm away and separated from my immediate family, and that's tough. My wife, her immediate family are all in lockdown in Malaysia, and that's tough. So actually work-wise, I'm totally okay. I have a great bunch of colleagues and a great team, and the country's managing it. But on a personal level, it's in times like this when you realize that everyone's going to lock down their country, that suddenly you're quite stranded and separated from people. And that is quite hard to deal with in that regard. So yeah, I'm doing great. Thank you. But it would be nice to be able to see my family soon.
Ram? How are you getting along, Ram?
Quite similar to what Andrew said. Look, it's a privilege to be a part of a system where I am taken care of. At least now when I work with COVID patients, I don't get the fear that I'd be infected one day. At least there is at least that feel of safety within yourself. But definitely, it feels a bit sad that we are away from our immediate family and others. We need to be careful at home too. I got 2 small kids who run to me as soon as I reach home. So I got to make sure, the policies and the practice of social distancing is practiced at home, which is very difficult. So, challenges are from a different front when you have this kind of distancing measures.
Mm-hmm. Deng Wei, how are you getting along?
I'm okay. So I think we are quite fortunate here that we are not worrying about the adequacy of PPE and other protection. So we are rather fortunate. And in a personal level, I'm very involved in ramping up in this the new ICU. So we are also in preparation phase in ramping up ICU services. So we are actually very busy with that. And but otherwise, the on the ground, everyone is coping, and we have been keeping an eye on each other, our colleagues. So, yeah.
Mm-hmm. And Raj, I guess you will give you the final say for this, but how are you coping?
I think it's been a big learning journey for not only me, but for everyone really. We're learning new things every day, especially in setting up of new areas around the hospital. I think it's been really heartening how the whole world is communicating on this and sharing in a way like never before. Andrew and I were just talking to Imperial and UK a few days back, talking to you now, and a few more lined up as well. And it's amazing that this whole culture of sharing it just shows that we're all in this together. And I think on behalf of Singapore, I'd just like to wish Australia all the best as well. Good luck and stay safe.
Thanks very much. And Andrew, I must acknowledge my old friend Alex Chow, who was a vascular surgeon at Tan Tock Seng Hospital, who unfortunately died during the SARS era in 2000. And I think some of the stuff that you guys are doing are stuff that, Alex went through. And I wish, and just on behalf of, all my colleagues here in Adelaide, really hang in there, guys, and thank you.